Welcome to The Explainer. Today, we're unraveling what's honestly a true medical detective story. We're looking at a disease that's been haunting humanity for centuries, and it has this terrifying ability to just hide in plain sight before unleashing a totally grueling, exhausting ordeal on the human body. We're talking about whooping cough, or as it's clinically known, pertussis. You've probably heard it nicknamed the 100-day cough. In this explainer, we're not just going to look at what this infection actually is, we're going to break down the whole timeline of the battle, exactly how we treat it, and most importantly, how we build a defensive wall around our most vulnerable patients. Okay, let's dive right into this. Here's our clinical checklist. First, we'll meet the pathogen. Then we'll map out those 100-day cough phases. From there, we'll hit targeted antibiotic management, public health defense, and finally, how we protect those high-risk, vulnerable groups. All right, section 1, meet the pathogen. Because before we can really understand the disease, we've got to profile the microscopic culprit we're actually up against. Now, what's really interesting about this is the precise biological profile of our culprit, Bordetella pertussis. If you're studying for the MSRA or just brushing up on your microbiology, this is an absolute must-know. It's an encapsulated, aerobic, gram-negative Coccobacillus. So let's decode that a bit, right? Being gram-negative and encapsulated means this bug has a really robust outer defense mechanism. This lets it easily attach to the cilia, those tiny hair-like structures lining our upper respiratory tract. And it's aerobic, meaning it needs oxygen to survive, which is exactly why it absolutely thrives right there in our airways, just setting up camp and releasing toxins that literally paralyze our natural clearing mechanisms. And once this pathogen takes hold, it triggers a very specific sequence of events. So let's get into section 2, the 100-day cough phases. And this brilliantly illustrates just how grueling and escalating the arc of this disease really is. Guys, it's not just a bad cough. It is a marathon. It kicks off with the catarrhal phase, which lasts about 1 to 2 weeks. The patient's going to have coryza, just a runny nose, maybe a low-grade fever, and a mild cough. But then we hit the paroxysmal phase for 1 to 6 weeks. This is the hallmark stage. Patients go through these intense, severe bursts of coughing called paroxysms, and they often look completely exhausted, even though they might seem relatively fine between the episodes. Finally, there's the convalescent phase, and that can drag on for up to 3 months. The paroxysms slowly fade out, but the airways are just so hypersensitive at this point that even a simple cold or a tiny irritant can spark that harsh, dry cough all over again. So here's a classic MSRA style question for you, and it definitely requires a bit of clinical reasoning. Looking at those 3 distinct phases we just walked through, during which clinical phase of pertussis is the patient actually the most infectious to others? Think about it for a second. Is it when they're coughing the absolute hardest? Well, surprisingly, no. The answer is the catarrhal phase, those very first 1 to 2 weeks. And this is exactly what makes Bordetella pertussis such a stealthy, effective spreader. When the patient is the most contagious, their symptoms are literally at their mildest. To a doctor, a parent, or coworker, this phase is virtually indistinguishable from just a run-of-the-mill common cold or a standard upper respiratory tract infection. So by the time the severe coughing actually starts, that peak infectious window has often already slammed shut. But how do those severe coughing fits actually present? Well, it heavily depends on who you're looking at. Over on side A, we've got children. They experience those intense paroxysms that end in that classic high-pitched, desperate gasp for air, the whoop, which is very often followed by post-tussive vomiting right after the fit. But take a look at side B. This is a massive clinical trap. In adults and adolescents, that famous whoop is frequently completely absent. Instead, they usually just show up with a prolonged, persistent, and totally exhausting dry cough. So if you're a clinician just sitting there waiting to hear a whoop to diagnose an adult with pertussis, you're almost certainly going to miss it. Okay, let's move on and see how this builds into our clinical response in section 3, targeted antibiotic management. How do we fight back once we identify it? The absolute magic number here is 21. Now, antibiotics actually don't dramatically alter the course of the illness once the patient has already reached the paroxysmal phase. The damage to the airway cilia, it's already done. But prescribing antibiotics is absolutely critical within the first 21 days of symptom onset. Why? Well, because within that 21-day window, antibiotics eradicate the bacteria in the nasopharynx. This effectively stops the patient from passing the disease on to anyone else. So it's just as much a public health intervention as it is a treatment for the individual. And here's our clinical playbook straight from the NICE guidelines. Notice how our strategy completely shifts based on patient demographics. For infants under 1 month old, your first-line choice is clarithromycin. If that isn't working, you absolutely must consult a specialist or a pediatrician. Now, for children over 1 month and non-pregnant adults, you can roll with azithromycin or clarithromycin, keeping cotrimoxazole in your back pocket as a second-line alternative if the macrolides just aren't tolerated. But take a really close look at that bottom row. For pregnant women, the first line there is erythromycin. Which brings us to another really highly tested concept, and honestly, a vital point for prescribing safety. Why exactly is erythromycin singled out as the preferred macrolide over azithromycin or clarithromycin, specifically when we're treating pregnant patients? So, the crucial point here all comes down to the data. Erythromycin just has the most extensive safety data and the most firmly established historical profile regarding fetal safety. When we're treating a pregnant patient, we obviously want the most predictable, historically vetted medication available. Plus, as we just noted in the table, that second-line alternative, cotrimoxazole, is strictly contraindicated in pregnancy. That's because of the severe risks of folate antagonism, especially in the first trimester, which can sadly lead to neural tube defects. Definitely something we want to avoid. Of course, treating the individual is only half the battle. Let's transition to Section 4, Public Health Defense. How exactly do we contain an outbreak once it starts? The key number you've got to remember here is 48. This is the strict school and work exclusion rule. If someone is diagnosed with whooping cough, they must be completely excluded from nursery, school, or work until 48 hours after they've started appropriate antibiotic therapy. And if they're untreated for whatever reason, they have to stay away for a full 21 days from the onset of the cough. This hard boundary is absolutely crucial. It's what actually stops the pathogen from just sweeping through a classroom or an entire office floor like wildfire. But what about the folks who have already been exposed back at home? This is where post-exposure prophylaxis, or PEP, comes into play. We offer prophylactic antibiotics within 21 days of symptom onset in the initial case to basically build a defensive shield around high-risk household contacts. So who gets this? Specifically, we're talking about households that have unimmunized infants under 1 year of age or pregnant women who are in their 3rd trimester. We want to aggressively intervene to make absolutely sure the bacteria never even gets a chance to reach these highly susceptible people. Which brings us to our final and definitely most critical section. Section 5, Protecting High-Risk Vulnerable Groups. Why do we go to such incredible lengths to build this defensive shield? We do it because the stakes for our youngest patients are just incredibly high. Infants under 6 months of age face the absolute highest risk of severe, devastating complications from whooping cough. At this point, we aren't just talking about a bad cough anymore. We're talking about apnea, where the baby literally just stops breathing. We're looking at severe pneumonia, hypoxic encephalopathy, which is brain damage caused by a lack of oxygen during those terrifying coughing fits, and tragically, even death. Make no mistake, this is a life-threatening emergency for a young infant. The real problem here is that an infant's primary immunizations, like the DTaP vaccine, they don't even start until the baby is 8 weeks old. That leaves a terrifying 2-month window of essentially zero protection. So to close that gap, our primary protective strategy is maternal vaccination during the 16 to 32-week gestation window. By vaccinating the mother during this very specific time frame, her body goes to work generating these powerful antibodies that actually cross the placenta. So when the baby is finally born, they arrive in the world already equipped with this amazing borrowed immune system, ready to fight off Bordetella pertussis right from day 1. So by truly understanding the microbiology, the timeline, and our strict prescribing rules, we really can manage the spread. We've seen exactly how empowering maternal immunity ultimately becomes an infant's very first line of defense, essentially acting as an invisible shield for our most vulnerable. But, as bacterial strains continue to evolve and adapt over time, it leaves us with a pretty critical question to think about. How will our vaccination strategies need to shift over the next decade to ensure this 100-day cough doesn't outsmart our best defenses? It's something to ponder. Thanks so much for tuning into this explainer, and keep learning.